generally see patients on invitation. So we know we need to see a patient when someone calls us and requests our services. We will do follow-ups on patients based upon our own sense of how closely they need to be evaluated by the infectious disease services, or the hospitalist will call and ask that we do closer follow-up if that's what's needed. That's when we go and see a patient. The process is an on-call process, so I'm scheduled to see patients from time A to time B. That could be a shift, or it can be a weekend, or it can be a week. And within that, when patient requests come in for evaluation, I then see them in a timely manner, unless there's an issue of urgency, in which case we do it as soon as possible. So there's a difference between what I see on a day-to-day basis in my current practice and what I see in telemedicine. Currently, I probably see 30 to 40 patients a day in my current practice. And in telemedicine, I would imagine we average somewhere between 2 to 5 to 10, depending on what is happening at that particular time. Certainly with COVID, we were seeing a lot more patients. I think the amount of time diagnosing a patient includes a number of factors. So it includes talking to the physician who makes the initial request to have an infectious disease consult. It includes reviewing the electronic medical record and examining the microbiology and other tests that are there, including reviewing the patient's history. It includes talking to the patient. It includes evaluating and examining the patient via the telemedicine. It can sometimes include the time it takes in order to get the cart available so that we can have that discussion with the patient, and then writing a note to document what we're thinking. And so that process is dependent upon how complicated that particular patient is, whether they're in septic shock in the intensive care unit, intubated on life support medications, whether they're post-surgery, or whether they have a simple skin and soft tissue infection that might be easier to move things along with. You know, for many patients, it's their first time seeing a doctor in a monitor, you know, at the base of their bed, you know. And so, just like it will be for people who just start doing telemedicine, there's a bit of awkwardness in order to become familiar and comfortable. And I think we need to be sensitive to patients that this is their first experience over and over again, that they're not used to receiving medical care through a camera. And so it's important to introduce ourselves, to tell them who we are and why we're there, and how we're participating with the rest of the team in order to benefit them. We interact with most people within the healthcare team, so that will be the hospitalists or any other physicians who are taking care of that patient. In some places, it will be the nurse practitioner or the physician's assistant. In other venues, we might be talking to the resident who is seeing the patient and is part of a team at that hospital with an attending overseeing them. And our interactions are hopefully respectful, and they are basically, how can we help you here? You know, what is the need that you have at this moment for this patient? And then we begin the process of evaluation and coming to a treatment plan. That's pretty much the usual of what happens each and every time. And so the interaction is almost always a conversation with the other person, the other provider, and a review of the chart of the EMR to make sure that we understand what has happened so far and what is being planned. And often a discussion with the nurse, because they're there during rounds with the patient when the team is seeing the patient, and they'll have updated information for us as well. And this may include making calls to the microbiology lab. It may include calling the surgeon. It may include calling the intensivist. It may include calling radiology to clarify different processes. I think those conversations are crucial to the patient and to the healthcare team, so that everybody feels that we're working together and that things are not happening in isolation, which means that the type of tests being done, the evaluations that are ongoing are in discussion with everyone, even to the extent of whether the patient needs to have an upgraded type of care to a different hospital, if there is a need to move them out of a rural process into a more urban tertiary care hospital. So these discussions are always ongoing. So I think the same things we would discuss as an infectious disease specialist, whether you were in telemedicine or not, will remain the same. These include whether we're getting the appropriate test to make a better diagnosis, an interpretation and evaluation of the tests that have currently been performed, whether it's microbiologic or whether they're molecular tests, or whether there are different types of blood tests that are recommended to make a diagnosis, or whether there's a need for interventional radiology to do some invasive procedures to be able to get biopsies, or whether a surgeon is needed. We're participating in that whole process for the patient's care. We have to work with a lot of trust that they are our ears and sight and touch, in ways that we may not be able to have access to at that moment. So there's the trust that they're competent, that they're knowledgeable, and that they're involved in this patient's care. And we talk with them, the way we would talk to any other nurse. And we also have to be curious with them about the patient's care. What are they learning through the day that the other people on the team are discussing that would be helpful for us to know about? Because not everything that's discussed will get charted, and not everything is charted up to the moment. And so we rely on the nurses, not just for the physical exam, but for a lot of communication around what's happening with the patient's care. And that extends to what's happening with the patient and their family. What's happening to the patient and their discharge process. Are they going home? Are they going to a skilled nursing facility? What might we need to do to help that along? Do we need to change antibiotics to oral? Do we need to change antibiotics to once a day? Do we need to have the patient obtain certain types of intravenous lines in order to make that transition easier? So the nurse's presence is crucial. They are the eyes, ears, and they can palpate and create a sense of touch that we can't through telemedicine. And so they're there from the beginning of the video to the end of the video. And they not only provide help with the mechanics, but they also will alert us to things that we might need to see. And so they're crucial.